Good evening. I want to welcome everybody to this week's happy hour session, Sagis Diagnostics happy hour session. Again, as always, for those of you who are watching live, please feel free to use the chat for any questions that you might have. I'll be monitoring the chat, or you can email us at sagis@education.com or education@sagisdx.com, I'm sorry, or you can email me directly, tdavis@sagisdx.com. Tonight, we're very pleased to have one of my good friends, excellent dermatopathologist, Dr. Martin Fernandez, host our session. Dr. Martin Fernandez and I knew each other first in San Antonio, and he currently is head of dermatopathology at the Scott and White Hospital in Temple, Texas. Actually has a Dermpath fellowship there as well. And so we're very pleased to have him guide us through this week's sessions of unknowns. So again, if you have any questions, please feel free to let me know. And with that, I'll go ahead and turn the floor over to Dr. Fernandez. Martin.
Hi, everyone. Welcome to the Sagis Dermpath Happy Hour. I'm going to be your host for this session. My name is Martin Fernandez, and I'm a dermatopathologist here at Baylor Scott and White in Temple, Texas, where I'm also the director of the Dermpath Fellowship Program. Today, we're going to be reviewing a mix of cases ranging from more or less common to quite rare, and I hope you find them interesting. Before we start, I would like to just thank Dr. Tom Davis for inviting me to host today's session. And very well, let's start with the first case. Let me go to full screen. There we go. So the first case we have here, it appears to be an excision. And you can see it includes epidermis, dermis, and some subcutaneous tissue. You look at the epidermis, there is slight hyperplasia and papillomatosis. Also notice the basal layer appears to have increased melanin within keratinocytes. And then we start to notice as well many aggregates of cells embedded within the collagenous dermis, where the cells have abundant cytoplasm, have somewhat of a round to slightly spindle-shaped nucleus, and they correspond to smooth muscle bundles. And of course, normally we have smooth muscle bundles in the dermis in association with folliculosebaceous units, right? The erector pilar muscle, but these are really clearly too many of them. So that's definitely abnormal. And looking at another section, you have, for example, here a couple of folliculosebaceous units, and you have, just for comparison, look at some of the eccrine glands, and look at the eccrine ducts, right? So in addition to these adnexal structures, we have these larger ducts within the subcutaneous tissue and deep in the reticular dermis. And these ducts are lined by an epithelium that is hyperplastic and that shows papillary projections. And so now we have a constellation of findings that is, an epidermis that shows slight papillomatosis with hyperpigmentation of the basal layer, proliferation of smooth muscle bundles, and the presence of ducts that are much larger than eccrine ducts. Again, look at the size of the eccrine ducts here. So this corresponds to mammary ducts. So this, again, this constellation of findings is diagnostic of an accessory nipple. So it's a very, florid case of accessory nipple with abundant smooth muscle bundles. Okay, let's move on to the next case. And now here we have a punch biopsy. And you can see that there is a infiltrate that is superficial and deep, and it's arranged predominantly perivascular. Has a perivascular distribution, but it also has an interstitial distribution. So whenever you see an interstitial component in an infiltrate, that likely means that infiltrate is mixed. That is, it's composed not only of lymphocytes but also eosinophils and maybe also neutrophils. So let's see, and yes, we see that that's the case here. An infiltrate composed of lymphocytes, histiocytes, and numerous eosinophils. And again, superficial and deep. And also notice that within the epidermis, of course, there is this structure that is embedded underneath it's kind of burrowed underneath the cornified layer. And it's pretty large in size. So it's the size of a mite. And if we look at higher power, we can see that this it has an exoskeleton. And this material here likely represents fecal material. And so notice the location. It's a rounded looking mite that is burrowed underneath the cornified layer. So that's compatible with scabies, with a scabies mite. And another thing to mention is that, many times, at any given point, the patient only has a certain number of mites. So sometimes it's difficult to really identify the mites. So that's what we have to do many step sections to be able to identify. So this section that you're looking here likely represents the best section of maybe 5 or 10 step sections that the dermal pathologist did in order to identify this mite. So very well, so that's scabies. So let's move on to the next case. And so here we have a shape biopsy. And this is a shape biopsy from likely the head and neck region. There's some solar elastosis, and there's many vellus hair follicles. And there's some peri-infundibular inflammation. And if we look at some of the other follicles, we can see that within the infundibulum, there's another organism, another mite. However, instead of being more or less round, this is more of an elongated in shape. It has an elongated shape and is within the follicular infundibulum. And so this corresponds more to a Demodex mite. And so, yeah, this patient clinically had Demodex folliculitis, and the patient was treated and responded to treatment. So this biopsy really confirms the diagnosis of Demodex folliculitis. And I thought it was a good idea to show these two cases back to back, just to compare the morphology of the mites in scabies with Demodex. Again, mites in scabies are more round and are located underneath the cornified layer, whereas Demodex are more elongated and are located within follicular infundibula. So size and shape and location are important for distinguishing these two types of mites. And let's move on to next case. It's an interesting case. So here we have a bisected punch biopsy. By the way, there are 12 cases today, and this is case number 4. So this is a bisected punch biopsy. And at this power, we can see that there is a pigmented lesion. And, this power, notice that it is kind of small. It is well demarcated, and it appears to be symmetric. It is heavily pigmented, and the pigment is present within melanocytes. as well as within keratinocytes, and is also present in the dermis within melanophages. So heavily pigmented lesion. Many times, these type of lesions also have prominent pigment within the cornified layer. So with so much pigment, you can expect this lesion to be very dark clinically. Notice also that the melanocytes are somewhat uniform. They're slender and spindled in shape for the most part. Also, you have centrally some pagetoid spread. Some areas show better that feature than others. Yeah, there's some pagetoid spread there centrally. So, you know, this lesion has some features of concern, but in general, the fact that it's small, symmetric, and circumscribed, those are all reassuring findings. So the overall findings in this case fit best with a pigmented spindle cell nevus of Reed. And of course, it's important to be able to distinguish from melanoma. And just to emphasize, it's very important to notice that the lesion is small, is sharply demarcated, and is symmetric. So pigmented spindle cell nevus of Reed. Not to be confused with melanoma. Let's move on to the next case. It's another interesting case. Here we have a very generous specimen. It likely represents an incisional biopsy. And there's a lot of things going on in this specimen. So let's break them down. First, at this power, we can see that there are pretty prominent eccrine glands that are arranged as you know, their usual lobules. And there's also some dermal fibrosis. And there's some cellularity here in the upper reticular dermis, and we go in higher power and we notice that all of these represent small caliber blood vessels. So there's a vascular proliferation, very prominent vessels within the upper reticular dermis. So this likely, oh, by the way, the vessels are also present even in the subcutaneous tissue. Very prominent little vessels. And this specimen is from the lower extremity. So this vascular proliferation together with the dermal fibrosis is compatible with stasis changes. However, that's not the only finding in this biopsy. Some of you may also have noticed that there are epidermal changes. Notice that within the epidermis, there is this epithelial proliferation that is composed of very thin, elongated strands that are interanastomosing. See, interanastomosing thin strands of epithelium. And there are, there's a ductal lumen in many of these thin epithelial proliferations. Let's look at all the areas where there is a lumen. See, there's a lumen. And this very much looks like the acrosyringium of a duct of an eccrine gland. See that there's a lumen. So, and again, notice they are interanastomosing, and they're present in association with stromal fibrosis. Notice this fibrosis in the stroma around them. So the diagnosis here is that of reactive syringofibroadenomatosis in a patient with stasis changes. This is quite rare. I only see in a couple of occasions, so it's an interesting case. Reactive syringofibroadenomatosis in a patient with stasis changes. Very good. Let's move on to next case, case number 6. Yeah. So let's go to full screen. So here we have another shape biopsy, and at this power we can see that there is an infiltrate, pretty sparse infiltrate that is predominantly perivascular in distribution, and we can also see that there's epidermal changes. notice that the epidermis is slightly hyperplastic. And we go in higher power, you can see there's very prominent, very prominent granular layer. There's also hyperkeratosis. And the hyperkeratosis is composed of compact and basket weave orthokeratosis. There is no parakeratosis in this lesion. And you can also see that some of the reedy have this pigmented, this pointy shape of the reedy ridges. So actually, this findings reminds us very much of lichen planus, right? Wedge shape, hypergranulosis, pointy reedy ridges, hyperkeratosis, composed of orthokeratosis. There's also many necrotic keratinocytes. However, we don't have a very dense band-like infiltrate like we typically expect to see in lichen planus. But we do have pretty prominent interface changes, mostly vacuolar interface changes with many prominent necrotic keratinocytes present throughout this lesion. See many necrotic keratinocytes. And some of you may have noticed that some of these necrotic keratinocytes are present in association with a small lymphocyte opposed to it. So that's a so-called satellite cell. So everything together, all the findings fit best. By the way, this is, in this case, we do have somewhat of a mixed infiltrate with a few EOs, which can occur. And you also have some melanophages. But so the diagnosis for this case is graft versus host disease. So now graft versus host disease, of course, can be classified into acute and chronic. And, so clinical information is very important for the classification, but also it's important to keep in mind that both acute and chronic graft versus host are essentially interface processes. And in acute graft versus host disease, it's more of a vacuolar interface dermatitis without much epidermal change other than the necrotic keratinocytes and the vacuolar changes. Whereas, in acute graft versus host, you think in terms of the differential diagnosis, you think more along the lines of, could this be acute GVHD versus erythema multiforme? Whereas in chronic graft versus host disease is more of a lichenoid interface process. Not like, you have vacuolar changes, but lichenoid in the sense that you may have a little bit more of an infiltrate, and you definitely have other epidermal changes that mimic lichen planus. So in this case, hypergranulosis, hyperkeratosis, and so on. So I think altogether, this fits best with the diagnosis of chronic graft versus host disease. Move on to next case number 7. And here we have another bisected punch biopsy, and we have a pretty well demarcated cellular nodule in the upper reticular dermis. It's not connected to the overlying epidermis. The epidermis is slightly dome-shaped, so this likely looked like a papule clinically. And when we look closely at the composition of this cellular nodule, we see that it's composed of pretty monotonous small cells with a very round nucleus, and they are arranged as sheets, small nests, in a thin trabecula. Some of these appear to be embedded in a hyalinized stroma. And maybe the most important thing to notice is that they are arranged almost concentrically around little vascular structures. See, so they are distributed around. They have very prominent perivascular distribution. So this distribution, and particularly the monotonous morphology with a very round-looking cytoplasm, nucleus with amphiphilic cytoplasm, these findings are consistent with a Glomus tumor. It's a very characteristic example of a glomus tumor. And as you know, glomus cells are modified smooth muscle cells. So, not surprisingly, glomus tumor cells stain positive for smooth muscle markers. So this is a very typical example of a glomus tumor. Very good. Let's move on to next case. Here we have a bisected punch biopsy. And here we have another tumor that is involving the dermis that is composed of these smaller nodules that are blue. Notice that there is no connection to the overlying epidermis. And when we go on higher power, you can see that again, compared to the previous case of the glomus tumor, these cells are also small and monotonous, but not quite as monotonous and not quite as round, but still small, kind of monotonous cells. And notice there is no palisading, no clefting. So although in low power, you may consider briefly a diagnosis of basal cell, it really looks different than a basal cell carcinoma. And importantly, some of these little nodules have these ductular spaces. So these ductular spaces are very important for establishing this diagnosis. And again, notice small monotonous cells, very scant cytoplasm. So this combination of again, small monotonous cells, epithelial cells within the dermis, and in combination with ducts. So these findings are compatible with a tumor in the poroma family. And as you may remember, poromas may be subdivided depending on the compartment of the skin that they involve into 3 different types. So the poromas that involve exclusively the epidermis are called hydroacanthoma simplex, whereas the poromas that involve the epidermis and the dermis are just called poromas, and the ones that are confined to the dermis are called dermal duct tumors. So this is an example of a dermal duct tumor. And for the differential diagnosis, you may consider a clear cell, clear cell acanthoma or nodular hydroadenoma. But in that lesion, which is also, of course, a benign adnexal neoplasm, there you typically would expect either a solid cystic architecture, more of a clear cell change, or more just a squamous differentiation, which in this case, is not quite squamous. It's more again poroid, more than squamous, that you typically tend to see in nodular hydroadenoma. Very good. Moving on to next case. So this here we have another shape biopsy, and so we have another inflammatory infiltrate that is perivascular and periadnexal, slightly wedge shaped, and it is composed mainly lymphocytes and histiocytes, and it also appears to be obscuring the dermal epidermal junction focally. And so if we focus on this area of the epidermis, we can see that the keratinocytes are abnormal. Let's look at this other section. Yeah, you can see that the keratinocytes are definitely abnormal, especially, and I think it's always a very good idea when you're evaluating a slide and you're not sure about something is normal or abnormal, just to compare with a patient's background normal. So this is how the epidermis looks normally for this patient. And so we can compare that to what we have here. So here you can see that the nuclei are definitely larger. Not only that, but some of the keratinocytes have are multinucleated. And also, you may notice that the chromatin appears to be pushed to the side, and it kind of accentuates the nuclear envelope. And many of the nuclei are molded to one another. And also notice that the rest of the chromatin in the center of the nucleus is very homogeneous and has this characteristic appearance. Many people call this steel gray nucleus or steel gray nuclei because of how smooth the chromatin is and the color it stains on H&E. So these are steel gray nuclei that have the 3 M's: multinucleation, molding of the nuclei, and margination of the chromatin. So you guessed it, the diagnosis is herpesvirus infection. In this case, the patient had herpes zoster. So that's a diagnosis for this case. Very well, let's move on to case number 10. It's an interesting case. So I don't think we have to move this too much. But so in here we have a nodular lesion that appears to be in the subcutaneous tissue because, of course, we have some adipose tissue here, and we have no obvious dermis or epidermis. And it's sharply demarcated, and it's richly vascularized. So if we go in higher power, you can see that there are many vascular lumina throughout. And if we go even on higher power, we can see that really essentially the entire lesion is a vascular proliferation, in the sense that, you know, we have many vessels with patent lumina, but we have many vessels that appear to be collapsed. So really all of these are endothelial cells. Like the great majority of the nuclei that you see here within this lesion represent nuclei of endothelial cells, but, you know, many of them again are collapsed and don't have a patent lumen. But so this is a vascular proliferation, and notice that it is arranged in a very distinct lobular. It has a very distinct lobular arrangement or architecture, and it is very well organized, right? It is organized in a hierarchical manner, in the sense that you have larger vessels that progressively branch out into smaller vessels and do so progressively into branching out into very tiny little capillaries, and again organized as a in a lobular arrangement. You don't see any endothelial atypia. You don't see any piling of nuclei, piling of endothelial cells one on top of each other. So all of these are reassuring findings. So yeah, actually, all of these findings, this is a benign vascular proliferation with a lobular arrangement. So it's diagnostic of a pyogenic granuloma. However, you know, we all know that pyogenic granulomas are typically polypoid lesions, typically eroded or ulcerated, whereas this is a subcutaneous, well sharply demarcated nodule with a capsule. So that's a little bit unusual, right? And the reason for that is that, believe it or not, this is an intravascular pyogenic granuloma. So what you see here is a vessel, and within the vessel we have this lobular proliferation of vessels. So this is a diagnosis here is an intravascular pyogenic granuloma. Very rare case. It is the first time I see, so it's a pretty cool case. Excellent. Let's move on to next case. Here we have another punch biopsy. One second. Okay, it's not working. 1 second. Okay, it's fine. So here we have a it's not working. Apologies for that. Okay, there we go. Okay, so here we have a very punch biopsy with a very cellular infiltrate, and it's diffuse. You know, it doesn't have a perivascular distribution or interstitial, just a diffuse infiltrate. involving the entire, spanning the entire dermis up down into the subcutaneous tissue. The epidermis has a little bit of spongiosis, but it's otherwise pretty much unremarkable. And if we go in higher power, we start to see that the majority of the cells within this infiltrate are organisms. Look at that. So this dermis is really packed with organisms with very little inflammation. Lots of organisms and very little inflammation. And these organisms are relatively large in size and compatible with the size of what we would expect a yeast. So these are little yeasts, and they are surrounded by a halo, right? And so this halo is actually a capsule. And so if we were to stain, we don't have special stains here with us, but this yeast would stain positive with PAS, with GMS, and with Fontana stain. And the capsule will stain positive with Alcian blue and mucicarmine. So the diagnosis here is that of cryptococcosis. So yeah, very florid example of cryptococcosis, where you have many organisms and little inflammation. So this corresponds best to the gelatinous form of cryptococcosis, so-called gelatinous form. And this is in contrast with the granulomatous form, in which you have sparse organisms and more of a prominent granulomatous infiltrate. Notice that here we don't have very few, if any, histiocytes. It's mostly organisms almost replacing the dermis. So very clear example of cryptococcosis. Excellent. And moving on to the last case of today, this may be my favorite. I seen this from time to time, and it's maybe a challenge sometimes to diagnose, but this case is quite characteristic. So we have a very nice and deep punch biopsy, where we have a superficial but primarily deep infiltrate. It's kind of a bottom-heavy infiltrate that is involving the deep reticular dermis, and it's also involving the subcutaneous tissue. So these are dermatitis and the paniculitis, right? And notice that the way it's involving the subcutaneous tissue is within the lobules of the hair, of the subcutaneous tissue, rather than in the septa. So this is more of a lobular paniculitis. And then when we look at the infiltrate, it is composed of mostly lymphocytes, histiocytes, and we may find a few plasma cells. Yeah, only lymphocytes and histocytes. And also notice that within the subcutaneous tissue, we have areas of necrosis and hyaline deposition or hyalinization. This is also very characteristic. And finally, the last clue, let me show you a little bit the area of hyalinization with the subcutaneous tissue. And finally, the last clue is the presence of prominent dermal mucin. Very prominent dermal mucin. In this particular case, the epidermis was unremarkable. Maybe a hint of vacuolar changes there, but not very conspicuous. But we do have very, very prominent dermal mucin deposition. By the way, it's a beautiful stain highlighting the mucin on H&E. Not all the time we're lucky to see that, but in this case, it's a beautiful stain highlighting the mucin. So as you would have guessed it, the diagnosis here is lupus paniculitis. And that's the constellation of findings, the presence of a lobular paniculitis composed of lymphocytes, histiocytes, and plasma cells, hyalinization of subcutaneous tissue, dermal mucin. All of that is diagnostic of lupus paniculitis. One thing to keep in mind is that sometimes the differential diagnosis with subcutaneous panniculitic T-cell lymphoma may be a challenge. And what we always emphasize here is that in subcutaneous panniculitic T-cell lymphoma, you tend to have atypical lymphocytes rimming the adipocytes, something we typically do not see in lupus panniculitis. But if you have any doubt, it's always a good idea to do immunohistochemistry and T-cell gene rearrangement studies, and that will help you distinguish those two. Well, this was the last case of the day. I appreciate very much you joining us today. And again, I'd like to thank Dr. Davis and everyone at Sagis for inviting me to host this session. And thanks again. Thank you.
Thanks, Martin. Excellent, as usual. And again, if you have any questions, if you're watching live or if you're watching this on the YouTube channel, please feel free to contact us. Be happy to answer your questions. Hope everybody has a great evening and hope to see you soon. Thank you.